for us to give us an overview of the situation there. The talk is going to last for around 20 minutes, and then we will have a question and answer session afterwards. So if you have any questions, please send them in the Zoom chat during the talk, or comment them on the Facebook Live, and we will do our best to make sure that they are answered well at the end of the talk. So thank you, Stefan, for being with us. The floor is yours.
Thank you very much. Thank you very much for the invitation. It's always a pleasure to talk about something that I really like and really enjoy. Being working with pharmacoeconomics in outcome research for more than 15 years. Actually, my training is an oncologist, still seeing patients, and for a good reason, you know, only seeing patients without thinking about resource consumption and location is something that keep something missing. So if you don't fix the system, we're not helping the patients at all. And that's why I started working with pharmacoeconomics. I remember that I went to one meeting of the ISPOR European chapter in Firenze. And then I met Marilyn Smith, that unfortunately she passed away last year, but she was kind of the head of the Isport. So I talked to her and said, you know what, we have no charters of Isport in Latin America. And that's, no, we should have, because we can't afford whatever is out there. And that's why we need to start talking about economics. And it's about 15, 16 years ago. And she said, that's great. She got one secretary, said, she's going to help you to fix that. A few months later, we started the Brazilian chapter, and then Mexico, Argentina, Colombia, all of them just follow us. And now we have a huge presence of professionals working for economics in Latin America. And by the governments, by the pharma industry, by the payers, by the academy. And one good thing that we did was gathering people from all kind of stakeholders. So that's why I'm going to share with you guys in a few minutes some of our experiences, some of things that I believe that you have to keep in mind and learn regarding this field. Okay, let's move. This is pretty much standard. I don't have any kind of conflicting interest that can change whatever I'm going to talk with you guys. But let's start with Latin America. Just to understand, it's a huge place that is extremely complex with more than 30 countries, 14 territories, and we have all kinds of health systems in the country. And if you don't know, we in Brazil, even though we are half of the Latin America regarding population, we're the only ones who speak Portuguese. Everyone else speaks Spanish. I don't know if you guys know a little bit Spanish, but just to have an idea how complex it is, even though everyone is speaking the same language, to understand, a lot of people would call that popcorn, that is easy to understand. Here in Portuguese, we call pipoca. Camila can translate to you guys. I don't know how you say that in Sweden, but in Spanish, we can call it crispetas, cotufas, pocholo, pop. So even though we're talking about the same thing, we get a lot of ways to translate, or a lot of ways to communicate. And of course, this is only to illustrate language barriers, but it's a kind of, you know, correlation with culture barriers and economical, environmental, ethnic factors. So we get a lot of factors to call the same thing from different names, and healthcare will not be different. Yes, it's a huge place, 590 million people. I don't know the population of Sweden now, but I'd say that São Paulo by itself, one city, has more than 20 million people living. Can you imagine driving in a city with 20 million people? And the whole Latin America, more than half has no access to healthcare. You gotta keep that number in mind. More than half of the population in Latin America have no access to healthcare. That's sad. And of course, that's a lot of reasons. And to have an idea, some of the people in northern Brazil, by Amazon, they have to go by boat for 8 hours to see a physician, to see a doctor. Some of the cities, you need like 3 or 4 hours by bus. So you can make appointment to see a primary care physician. And I'm saying that not to complain, but of course you have to understand the environment before you try to build up any kind of solutions. And yes, whenever you have health technology, some really important matters, some issues are something that nobody wants to discuss. Whenever you come to a medical meeting, you say that you have something between whatever the physician is prescribing or is ordering and the patient to get that is something that people don't like. No, they invite me to all the meetings to talk about this kind of stuff. And it's like getting water in your beer, you know, you're spoiling the hype, like talking about health technology, very nice drugs, very nice tests, genomics, and medicine of the future. And then someone goes over there and talks about money, about resources, about how hard it is to pay to everything. It's like, I'm not the most popular guy in this kind of meetings because I'm trying to bring everyone to the reality. But one way to fix that, I invite you guys to check this train. Some of you guys are seeing the train going in that direction, in the direction of the tunnel, and some of you see the train coming in my direction, so in the direction of my keyboard. I know that some of you guys may not even see the train, but that's understandable. Now, after lunch, Friday, some people may take a while to be connected, but try to do something very nice that's moving the train to the other direction, okay? Only using your imagination. You don't have to touch, you just check the train and try to make your brain move the train in the other direction. It is easy to do that. And after you do that, it's even easier. When I ask you guys to understand the environment, and I always say that in pharmacoeconomics, we have to learn how to change the train direction. If you sell the treatment, try to understand how you can deal to buy the treatment. If you try to pay for the technology, remember that people need that technology. If you need the technology, remember that you're not the only one who needs it. So try to move your mindset to a collaborative and to a collective perspective, and that can help you to fix solutions. Well, first of all, we're facing a problem because, at least in Latin America, we're getting older. We're getting more like Europe, the population is getting older, and something like every 10 years, we're getting 3 months older. That doesn't look like something huge, but from a biological perspective, it's important. So yes, people are living longer. If they live longer, they spend more money, they get more diseases, and most of the time they spend a lot of resources. So this is not to complain, but this is one explanation why this field is getting so popular. And I'm sorry, I just left it in Portuguese, but you understand that we're talking about cancer drugs, for example. They come from very expensive up to exorbitantly expensive. So they are very expensive. I only using cancer example because this is my field, but it works for rheumatological disease, for cardiological disease, for vaccines, for whatever. We're facing only strategies and treatments that are extremely expensive. Just to have one idea, the average cost of a new cancer drug, it's about $10,000 monthly, okay? $10,000 per month to pay for one cancer new treatment. So it would be irresponsible if we don't get that in our agenda. So that's why we start talking in all the meetings about economical toxicity or financial toxicity. The patient has at some point to pay for these treatments, even though they have research, they have sometimes health insurance, or if they rely on the government payment, that costs, already, of course, that there's no such thing as free lunch. That cost is going to be incorporated in the resources that someone at some point of their life have to put money on it. Well, but if you ask me, okay, if I'm getting more money, at least I'm getting better results. Yes, we're getting better results with more resources, but they're not proportional. It's like in the past, every dollar, every euro that I put to change patients' life meant a huge improvement in overall survival and outcomes. So far, we're getting a lot of more money to only little movements in that line, in that curve of benefit. So if we're still doing that, it's going to be at some point, and I am going to spend a huge amount of money to move patients' outcomes by hours. So that's why we have to assume that people need to understand that not because the technology works that we should incorporate it. We have to understand when is that point of the curve that they say, okay, until here, I'm okay with it. More than that, I'm not. And I invite you guys to have this paper, this one Nature Reviews paper, that brings these different perspectives that you should keep in mind whenever you try to understand and bring solutions for this field. Let's start from the bottom. The patient only asks, okay, someone's paying, is going to improve my life, and this is a recommendation by my physician. That's okay. The prescriber, they ask, of course, about patients' viability to have that technology, but they ask about whatever they're going to get from the treatment. If I work in a hospital, am I going to give a hospital profit out of the treatment? Or they're going to spend money and they're going to complain and I may lose my job in the future? And of course, the payers and the gatekeepers have a lot of questions regarding unmet need, clinical innovation, budget impact, quality of evidence, health economics for cost-effective analysis, political motives, level of demand by the physicians and by advocacy groups or patients. Well, so whenever you try to build up solutions to healthcare and to health economy, you gotta keep in mind all those answers. You have the questions and you need all those answers. Don't get only the answers to get the prescriber happy, but remember that you need to talk to all the stakeholders. And yes, we're moving from old-fashioned way to deal with evidence to a more sophisticated way to check medicine. This is another paper that I invite you to have. This was published, if I remember, in Nature as well last year, about 1.5 years, when the new researcher, scientists inviting the old guy to maybe to retire the old style books. Instead of checking only statistical significance, we gotta check how important it is to have that incorporation for that system. So it's like we gotta check, hazard ratios, but we have to check about options. Just to have one example, we may face a lot of uncertainties to have a vaccine for COVID than for a cancer treatment, because we need that right away. And of course, when I have the perfect benefit, evaluate by a randomized clinical trial with years of experience, we may lose people, we may lose lives. So science is much more complicated than only checking statistical significance. We got to check how important that technology can be to improve patients' life. Well, and yes, we do spend a lot of time to blame someone. We blame the insurance because they charge a lot and they don't give whatever we want. The healthcare providers because they waste a lot of money. The consumers because they don't want to pay for anything, but they want everything. The government's easy to complain about them because they make a mess all the time regarding the economy and the environment. Lawyers that always jump in front of each other, so they whenever you try to make a deal, they may, you know, postpone the interest before. And of course, whoever is selling the technology, they want to make a profit out of it. So don't spend that much energy trying to blame someone, because all of the stakeholders have some kind of blame in this situation. And of course, but there's something that we all agree that at the short, we have a short blanket. If you want to incorporate some technology, and NICE is a kind of benchmarking regarding the decisions in healthcare, and correlated with value-based medicine, is that if I want to incorporate any kind of technology, I got to keep in mind that I need budget enough. So I need courage to get some technology out of the same list. So how we do that? How we do that without getting people upset about not having everything and only making the list worse. This is we're facing a time that we have to take hard decisions, but everything is getting so expensive that people that not used to talk about health economics, they're getting close to. If you guys didn't read, you should read that Siddhartha Mukherjee. He got the Pulitzer Prize for The Paradox of Analysis, a nice book regarding cancer. But he talks about technology, he talks about genomics, he talks about a lot of information, and then he tells a nice history about the disease. And we come into a place that we have technologies in cancer, such as CAR-T, that I can get that patient's disease out of his body, fix the genetic, and give it back to the patient. That's amazing, curing a kid with leukemia using this technology rolls a tear. But when I get the price that's like $500,000, rolls another tear. We cannot afford to have the technology to everyone, unfortunately. So how we do to set the priority? And that's why we study health technology assessment. On one hand, I have to keep all the costs, including everything that I'm avoiding, indirect costs. I believe you guys already been studying that, just to make sure everyone is the same page. And on the other hand, I have to get all the outcomes. And there's a lot of way to do that. Again, costs, not only the cost of the treatment, and I gotta keep in mind costs, intangible costs, indirect costs, and we need to tropicalize data. If you come to Brazil, if you come to Latin America, you're probably gonna see costs, very inexpensive treatments in hospitals. If you go to US, it's very expensive costs in hospitals. So I'd say that in Latin America, we still see direct costs as the major problem, because first, we don't measure the rest, and because they sometimes are not expensive at all. Physicians are very inexpensive. Hospitals, they're not a big deal, but treatments that come from another country, they are very expensive. And then I go to my analysis. It can be cost minimization, cost benefit, cost effectiveness, cost utility. Doesn't matter. I believe you already know the definitions, but just to make sure everyone understands, cost minimization in healthcare is very unlikely to have, because it's not very common to have equivalent benefits with various treatments. Cost benefit, I'm talking about money divided by money. So it's like how many vials of that treatment I'm going to buy. If I buy more than that, I get a better price. So I'm talking about cost benefit analysis. Cost effectiveness, that I'm, dividing money by outcomes. Like, that's why it calls cost effective. I'm talking about that amount of money divided by over survival, divided by disease-free survival, divided by symptom-free survival. And cost utility is much better, because I can adjust for quality of life. So the big question that some countries have already the answer, and we don't, is when I'm going to call cost effective or not. So the threshold to define cost effectiveness, the World Health Organization sets as 3 times the GPD, okay. US mentions $50,000 by quality adjusted life year, that's okay. UK mentions something about 60,000 euros by quality, so that's still okay. We don't have in Latin America, no country with the threshold decided. Of course, we do need to adjust for quality of life. This is one example. And I have to remember that whenever the preference weight is set by any kind of patient, that can be changed if you ask physicians, patients with another disease, people without any kind of disease. So the methodology to get this kind of preferences are very complicated, and they has to be tropicalized again. So whenever you're trying to provide some information for another country, you have to remember that the preferences for that country can be different. And then you can set the model. Markov's model probably is one of the most popular, but it's not the only one. Of course, you don't have to talk about that. That's not the reason we talk. We get a lot of, definition of cost effective by the cost by quality, but I'm bringing this slide in this table just to show you that it's very unlikely to have technology that is really cost saving. So that costs less and is even better. It's very unlikely. But if you ask like 9 out of 10 physicians in Brazil, they don't know the difference of cost saving than cost effective. They don't understand that cost effective means spending more money for a better outcome. And only cost saving is spending less money for a better outcome. So education is still something that we need. Of course, we need as well define how much we are willing to pay to change that outcome. So the threshold for cost effectiveness is still being a moving target. We don't have that definition for any country in Latin America. Anyway, one good way to try to bring solutions is always, we published that in Lancet last year. Well, the reference is not over here, but anyway, believe me, we published in March last year in Lancet this paper that regarding next generation sequencing, a test that it's mandatory to treat patients in some diseases such as lung cancer, colon cancer, melanoma, and breast cancer. We need that information. Otherwise, I'm not treating the patient in the right way. So sequencing the genomic of the patient gives me information that are vital to decide what kind of treatment I'm going to give. Okay. Well, but to incorporate that in the Brazilian system, it's not only showing that it works. I need to respect national guidelines. I do need accreditation and quality definitions so the payers can double check if everything is being done in the right way. Medical education is really important because physicians still don't understand most of the things that we talk about. Education and awareness of the patient is something that, of course, can improve the system. Getting a database of information, and so that information can provide data and feedback the system, so we can prove the results in the future and work with the real-world evidence. Yes, it's something that we have to keep in mind as well. Of course, respecting patients' autonomy, privacy, and then we provide cost-effective analysis. So all that steps, and they come together, are important. So instead of selling technology, I'm providing solutions. Yes, if you want to get a payer's attention in the environment in Brazil, in Latin America, Mexico, Argentina, Uruguay, Colombia, you get a better chance if instead of providing information regarding any kind of product, you provide new novel models of arrangements, like cost resharing agreements, bundle agreements, and get a lot of, and you have to study that, new agreements that can feel more confidence than the fee for service. That the fee for service, so paying whatever they're spending is not a good strategy. So if you come with a new technology, I said, okay, just leave in my list of procedures that I have to study about it. But if you come with a new model of arrangements between payers and providers, you get my attention. You're going to be the first one to be listened, because there is a strong willing to at least feel how new strategies can fit in the system. We know that the fee for service is going to be there for a long time. They're going to still in the system, but they probably going to work together with other strategies. And yes, you got to show we're never going to incorporate new technologies and invest in innovation if we don't stop paying for wasting. It's like the choose wisely. It's something that I advise you guys to follow as well. In all the medical technologies, in medical fields, they have a list of procedures that should not be done, that we all agree that are not good technology, like tumor markers for patients without cancer. That makes sense. Like having screening of prostate cancer for a patient with 95 years old. Doesn't make sense. It's like asking for a lot of preoperative treatments for a young patient without previous disease. Doesn't make sense. It's wasting of money and wasting of time for the patient. So if we educate people, physicians, and even the patients, to avoid this kind of waste, we can have some extra money to invest in innovation. Latin America has a lot of opportunities to work with. You're probably going to see a huge interest regarding public-private partnership. The public-private partnership have been described in Chile, Mexico, Peru, Colombia, Honduras, and maybe in Brazil in the future. And of course, I don't have to mention that this is everything that I mentioned is previous to the pandemic world. So some of the partnerships, some of the definitions, the decisions may change, or at least, you know, the velocity, the speed of the willingness to pay for that new technology, new strategy can be changed because of the pandemic, because we set new priorities so far. But at least having public-private partnerships is something that most of Latin America are working with, because they understand that still doing the same thing that we do can be available. Well, but whenever I'm talking about solutions, you have to remember that solution means to everyone. For those who have a phone, you can always use that QR code so you can access the whole paper, but it's easy to find later. We published that in Value in Health a few years ago about equity. Just check the number. You know, in Brazil, we spend 9.6% of our GPD in healthcare. 9.6% is not that bad. The problem is that half of that, actually more than half of that 9.6 are spent with those patients with private insurance. 25% of the population with private insurance spend more money than 75% of the people who relies exclusively in the public system. So we have two countries over here. I'm going to repeat the number. 25% of the population have private insurance in our country. So something around 40 million people. Everyone else, more than 150 million people, only have public system. But those 25% spend more than half of GPD of healthcare than everyone else. That makes inequity a problem, a huge problem over here. And that's bad because that kind of inequity is strongly correlated with outcomes. We're not talking about going to airplane with, you know, first class and then business class and then coach, and you say the plane is going to go to the same place Safety protocols are the same. Of course, if you're in the business class, you have a better place to lay down, you have a better food, and you are going to be the first one to get in the plane and the first one to get out. But it's going to be safe enough. And we are going to the same destiny. In the public system, those guys are in the public, they have a better care. So they have a safer plane to fly. And because of the pandemic, we said we can see that better. You know, one patient, I always say that we are not in the same storm. We are not, we are not in the same boat. We are in the same storm. Some people have a better boat. The chance of having people without health insurance going to the hospital and die is 3 times higher than people with private insurance. And that's sad. So if someone comes to my office with cancer, I need to ask them if they have insurance, because if they have insurance, they have a better chance of survival. And that's sad. We have to fight against it, because, you know, we can't have people first class Latin American people and second class Latin American people. Everyone should come to the same place with the same opportunities. And of course, if you have a private insurance, yes, you can have a better bed, you can have a nice view, you can have you know, a cooler in your room, you can have priority to make appointments, but never have a better chance of survival. And again, the pharmacoeconomic benefits, and talking about pharmacoeconomics, never been so close to people, regular people. I saw a patient a couple of days ago, and he asked me how much was the price of the treatment. Fortunately, he had health insurance, but I told him it's something around $10,000 by month. And so he said, "Oh my God, we can provide an intensive care unit for people with COVID with this kind of money." I never imagined, you know, people understanding this kind of dealing in healthcare before the pandemic. So keep
Stefan,
that picture.
Just to let you know, we have just about 30 minutes left in the session. So
yeah, I'm finished. It's my last one.
Problem.
So let's keep in mind this picture, that, you know, inequity plays an important role, and that's really correlated. Whenever people spend more money in the private care, they can't afford, the price gets so high that they can't afford having a private insurance, so they go to the public system. So having any kind of incorporation, even though it's for the private, that can have correlation, yet it will have correlation with the public system. And this is, yes, this last slide, this is a dilemma. If you push that fat guy, you kill him, but you save 4 people that are in front of the train. I started the train, I'm finishing the train. Let's make it even worse. The guy is in front of the train. If you tell him to move, you save him, but it means that you're gonna kill 4 of them. Would you kill the fat man? No right answer, no good answer. That's not bullying, please. This is only a question without answers. In healthcare, we do that. Whenever we allocate resources to one direction, we getting resources from the other one. So taking decisions such as buying chloroquine for try to deal with COVID is like decisions to not invest in another drug that may work. So no answer, but, you know, we keep the strange taste of not having an easy solution for those patients. Well, that's it. We still have like 30 minutes to Q&A, and back to you, girls.
Thank you so much, Stefan. That was really great, and a great introduction to market access generally for people who don't have the background. I would be really interested to know how much you think that the different actors are aware of health economics and how important it is, especially in all the different systems, which you have obviously have experience of.
Yeah, I'd say that, well, so far, you know, we've never been so close to debate health economics in Latin America as we're doing now. Because, you know, after 15 years in this field, At least now, the decision makers, they start understanding the background, definitions. But one easy mistake that we see all the time, people who work with health economics, they assume that people who work with healthcare understand that, and they never understand that as much as they should. They just checking the prices instead of value. They're just checking the costs instead of the opportunity. Just checking the budget instead of cost-effective analysis. So one part of the solution is to educate this kind of people, to bring them to understand that whatever you did to get to that conclusion. So I see that all the time, presentations, very nice presentations actually, but that presentation is very good for the speaker, not for the audience. When they try to sell some technology or sell some definitions or some concepts, but they try not only to make people think and they get together in the same conclusion, but you try to push a conclusion. In Latin America, especially in Latin America, you have a lot of passionate people. And it's like, if you speak Spanish, you understand, they say like, tenemos que cambiar la cabeza de todas las personas, like we gotta change everyone's mind before you incorporate everything. It's not possible, So you have to bring them to the floor and say, what do you need to get the conclusions that provide benefit for the patients? And that's the challenge.
And what do you see as the role of ISPOR? I mean, the local chapters and maybe even the international community.
Oh yeah, sure. That's right. Well, the good thing about at least Isport, they set definitions and they set some kind of compliance rules, guidelines, and they provide education that can be extremely reliable education that can be extremely useful, especially because the distance between interests are equal. So I'm not trying to protect the industry. I'm not trying to protect the payers. I'm not trying to protect not even the patient. I'm trying to protect the science, and that's important. Local chapters, they are very good because sometimes they deal with problems. I've been working with the Latin American Consortium, and whenever we get together, people ask, hey, how did you get the guy from the government? So I help them with the strategy. Some people say, okay, I had a lot of people from the pharma industry over here, and all of them want to show that they benefit, their product is better than the other one. How do you deal with this kind of fights? So we learn from each other the strategies, and if you get the same language, if you get the same approach, we build up more credibility.
So now we have a couple of questions in the chat. Delia is asking, she says, I'm interested in how big the phenomenon of pseudomedicine is in Latin American societies and if people rely on it and trust it in the absence of access to healthcare.
Okay, that's a good question. Well, let's say that medical students, and they never been involved with healthcare decisions before. I've been struggling to have that incorporated in medical curriculums and providing at least extra wall training regarding as soon as we can, as this generation are trying, probably you guys have to fix the world pretty soon. So educating students are extremely important, because it's going to be pretty soon you have to take the decisions that someone should be done in the past. Well, second, we get a lot of difference between those students from very high, nice quality medical schools, and some of the students are just trained to solve the problem in the small cities. So they don't have that enough background to try to change the environment. I always say that we got to deal about treating patients, fixing patients' problems, but fixing the system as well. So you got to find out in the training, and that's one part of the chapters, and the student chapters especially, is to find out who's the one who has guts to go in that field without seeing the patient as a second part, but especially understanding that the collective perspective is much more healthy than just checking the problem of one patient. Is there a lot of work opportunities? Yes, it is a lot. Well, but yes, we do need, you guys have to speak Spanish most of the time. You know, speaking English in Latin America, you may have a chance in big cities, but at some point, it is important to talk with the same language, just like going to Asia. At some point, if you only speak English, you're gonna have a hard time to understand. But Spanish is not that easy, hard to learn. You know, you can take private Portuguese classes with Camila. She's doing that for a fair amount of money, no problem. And Spanish is pretty much changing some words, but yes, most of the countries need the language, so you have more confidence and you get more opportunities.
Question from Bruna. Sorry, would you like to read it or would you like me to?
Yeah, much of the new medicines be submitted for agencies. They're not more efficient. Safe, at least they are safe and efficient, but they're not more efficient and safe than whatever we have already. And especially they're much more expensive than whatever we have already. So those intangible costs, yeah, they're part of the business, but they're not a big deal. You know, if you want to bring some solutions to payers and to the agencies, first of all, they're going to ask you if you're changing overall survival, patient's chance of being cured. If you're changing quality of life, you need an instrument to measure that. But if you don't have it, you're trying to make some surrogate endpoints, especially those not so common surrogate endpoints. You have to make sure they understand that you have a correlation with this kind of surrogate endpoint with hard endpoints. Otherwise, they're gonna feel like you're trying to invent something so you can push your technology. If you don't build up trust, you're never gonna ask to make them to understand. We see that, there's a lot of agencies. If you focus in the Brazilian agency, you get a better chance to get spread all over the country, the region, because like Colombia, Argentina, Uruguay, Chile, they just wait for a while. They see whatever the Brazilian agency are doing, and then they make it again because it's much cheaper to copy the strategy than build. Then hire a lot of people to do that. But yes, they need people inside of the country to make that information reliable for that scenario. So bring intangible costs. They only make sense if you can prove that can make difference for patient's life, really.
There's another question from Delia about the importance on the development role of community care providers in Latin American regions where access to primary care and secondary care is difficult.
Well, let's see. Where's her question again?
It's just above the one that you answered. It's about the fourth one.
Oh yeah, sure. Communication healthcare has been a barrier. It's changing our jobs in all the site. Yeah. Well, I see this whole pandemic. We're talking about that before I start talking. That you can see opportunities in this stuff. You can always showing people that health technology assessment training and providing information is useful. Sometimes they don't use that, but not having that can be a barrier. So if you wanna bring up any kind of technology to any of the countries, it's prohibitive not having data regarding cost effective comparing to everyone. We don't care about being cost effective by itself. Nothing is cost effective by itself. But I like to see all those kind of analyses. And of course, we're talking about a well-done analysis, comparing all these opportunities, all the strategies that we have. So don't worry, we're not only building airports after we fix all the roads. So I say that allocating resources is not only getting the basic, the primary care. Part of the health technology assessment is to help decision makers to understand that, yes, some ethical decisions should be incorporated in our field before any kind of costs. You may remember that those kids in Chile that got stuck in a cave like a few years ago. I'm not quite sure when it was, but something like 5 years ago. And they have those kids, a soccer team, or I believe they got stuck in a cave, and the water came, they almost flooded, they almost died. And they spend a lot of money to save those kids. Nobody's asking about cost-effective analysis in this kind of, movement. We need to save the kids, and then later we're gonna check about the costs. It makes sense to get cost-effective analysis in everything. But yes, we do understand that measuring that and having the information for the right people are mandatory.
I think our next question is also from Bruna, and it's about communicating the role of HTAs to society. It's also in the chat if you want to read it as well.
Yeah, we do need to provide information. I'm not quite sure Latin American people are already mature enough to understand the concept, but they never been so close to taking decisions in healthcare as they are now. Because most of the people that are not in the field, they believe that, if it is good, should be done. That's it. We don't care. But whenever I say that, okay, how many people are going to benefit and how many people are going to be out of the system because of that decision? That's the question. Just to give you an example, they're trying to pass a law in Brazil that all kind of oral treatments for cancer, once it's approved by Anvisa, by our agency, has to be paid by the insurance, okay? Only by the insurance. Well, of course, we have to mention that inequity is going to be even worse. So I have a new drug. If they have insurance, they don't care if that drug is better than whatever we have already, but it has to be paid. And they're not taking care of 75% of the population who has the same disease, the same unmet need, but won't have that technology provided. Well, so they invite me to go to a government meeting and ask about that kind of stuff. I said, I'm an oncologist. I would love to have all kind of treatments available so I can choose the best one to my patient. But if I do that, I may benefit 20,000 patients, but I'm not quite sure how many patients are going to have a hard time to pay for the health insurance because of this kind of measurement for next year. So, yep, I have a problem over here. Without measuring, without having the numbers, I'm not taking decisions. I'm not making, any kind of benefit for anyone without making sure the difference between those who's going to benefit and those who are not going to benefit, and all of them are going to pay for that. So communication to the population, to the society, it is part of our job. The hard time is to make them understand. It's very easy to misunderstand this kind of concept. They may understand that, you know, we should not be involved in any kind of decisions, and magically we have resources to everyone.
And where do you think the main information gaps are in Latin America in terms of not only institutionalizing these kind of decisions, but also in explaining it to the public in
It's a lack
general?
of trust, you know, to be very honest. I believe that because no one is leading, there's no leader to this kind of debate. Like if the government says they have an conflict of interest because the most important payers. The academy sometimes too far from their reality. They don't deal with the real world problems because they stuck in the academy. Hospitals and pharma industry, they want to spend money, that's fair enough, but of course you have to be very carefully whenever you to get all the information that comes from them. I'm not saying that they're lying, but sometimes they're not seeing the whole picture, and that's why we need leadership, and leadership that is something that I call equally distant from all kind of interests. So I'm just trying to provide information, make everyone understand how important it is to deal with this kind of stuff, instead of only, you know, providing solutions by whoever's paying you to do that.
Might be a slightly unfair question, but do you think that ISPOR is being successful in doing that, in providing that kind of a leadership?
Well, to be very honest, I believe that ISPOR is the best option that we have so far. You know, we get another institutions trying to do that, and some of them are too linked to governments, so there's a kind of, you know, bias to the government. But ISPOR is not only one institution. Let's make it fair. You know, some countries, you got to keep in mind that they are sometimes too linked to pharma, and some places they are too linked to academy. Sometimes they have a lot of people from the payers involved. So leadership means to be fair as well. So one hard job of esports, and I say esports because there's a lot of esport chapters all over the place, is to make sure we keep distance from this kind of interests. It is a challenge because, you know, someone has to pay for that, and sometimes who's paying for that doesn't like to know whatever I'm trying to say.
And what do you think is the kind of direction for research in terms of supporting this? Since we're all currently students, what can we...
Oh yeah, sure. Well, you know, I would start with simple stuff like education, to understand, for example, how much people are willing to pay for some kind of preference. Like, let's see, just like I got some of my students and they asked me about the same. And I told them, okay, let's try to understand how much it is important to treat lung cancer. That's my field. And let's ask people with lung cancer, with another kind of cancer, with physicians who deal with cancer, such as oncologists or surgeons, physicians who don't lead with cancer at all, and payers. And let's see how the answers are different. They are completely different. So making, you know, the basis can help a lot. You get a huge chance to publish that, and you get a huge chance to help another research to not go to the wrong direction. So one piece of advice that you should take home is do the questions that you know already the answers, but you not really know. You don't really, but you don't have the answers. You believe that you do, but you don't. So another example, I went to Malaysia, to Kuala Lumpur a couple of years ago to present one study. I learned two things. First, I did a really good question. I asked people from the private setting about NHS, the sequence analysis. That's really important for cancer, okay? lung cancer, as I mentioned before. In the private setting, in the public setting. In the private setting, 98% of the patients they knew about that technology, and they some point had that information provided by physicians. In the public system, 98% of the patients didn't have it all because they didn't have the medicine. So does it make sense to have the test if you won't provide the drug for the patient? So just showing this inequity was important to provide the information in Kuala Lumpur. The second thing that I learned, that in Kuala Lumpur, I was allowed to have 3 wives. I don't know how they deal with that. I have 1 wife is hard enough. So it's very complicated to have 1 wife. Having 3, oh, it's crazy.
A full Ispor chapter's worth. We don't have any more questions in the chat unless anyone has got something burning right now. I think we can draw it to a close, but that's been a really great session. Thank you so much. We're just sharing right now our upcoming events. So the next event is going to be in partnership with Chase. The last day to register is today. So if you are interested in it, then please do. They have a full day of events and ours is just one part of that. So I would encourage you all to register for that now. And then next week, the following week, sorry, we have something about the quality of life during COVID in the Swedish population. So that's obviously very new research and should be quite interesting. And then our final event of the semester so far, probably, is about careers in market access from KI alumnus Amy Laval. So please join us for those if you can. And finally, we have a survey. We have a chance to win a couple of books, very, very exciting textbooks on health economics and research and health systems. We just want to know how you feel about our events so far and if you would have any suggestions for us for the next semester, because we hope to continue putting on things that you all enjoy. So if you do have a chance, then the links are of course on our social media and you can contact us with any further questions. So without any further ado, I'll let you all enjoy your Friday nights and just thank you, Stefan, for talking to us.
It was a pleasure. Whenever you need, just let me know. Camila has all my contacts, and have a nice weekend, you girls. Bye-bye.
Thank you so much. Bye.
Bye.